we're delighted that Dr. Felicity Sapp is presenting with us today. She is Clinical Director and owner of OCD and Anxiety Psychological Services in Calgary. She has extensive experience treating children, teens, and adults with OCD. She is a board member of the Scientific Advisory Committee of Anxiety Canada and a credentialed member of the Canadian Association of CBT. She provides training supervision to therapists as part of the Pediatric Behavior Therapy Training Institute for the International OCD Foundation, and annually, since 2008, presents OCD and anxiety-related workshops in the USA and Canada. Thank you, Dr. Sapp.
Okay. All right, well, thank you everyone for coming. Oh, I have to get rid of this. I'm just going to start my slideshow now. I don't need to introduce myself, it sounds like, so I'm not going to do that right now. Anyway, I'm happy that everyone was able to make it. I know that it's early in the morning, and today is, as Julian was saying, this is the first in a series of webinars, just we're going to be doing 2. And today, what I'm going to focus on primarily is what you and your patient need to know before you actually start the ERP treatment. These are my disclosures. So from this webinar, I'm hoping that you're going to be able to describe the core components of CBT treatment for pediatric OCD, to be able to adapt that treatment to working with children and teens, and to be able to implement effective cognitive strategies when you're treating pediatric OCD, to understand what are the important steps when you're first starting ERP treatment, and also to understand the components needed to create a fear hierarchy, just as a first step of ERP. So the elements of CBT treatment are sort of 3 I look at, sort of getting ready for treatment, rewiring the brain and fixing the error message, and then taking it into the real world. And today I'm finally focusing on getting ready for treatment. Now, before we get ready for treatment, we need to kind of have an understanding of the where the child or the youth is developmentally. Now, in terms of their level of thinking, their ability to sustain attention, and how well they can tolerate anxiety. So in terms of their level of thinking, we want to see how well are they able to understand the concepts that you are introducing them to. With children, we know that the amygdala is quite prominent. And so what happens is they're very reactive. They're much more concrete in their thinking skills, and they tend to have poor insight into the OCD symptoms themselves. With teens, we tend to see that when emotional issues start to arise, that their complex thinking tends to, they're less able to be thinking in a complex way. And then finally, one of the things we see is that even though they're less concrete in their thinking and they can think in a more abstract way, they tend to be very black and white in their thinking. And what happens is that you can get caught up in rationalizing with them and get caught up with, someone's raised their hand, I don't know. I'm just going to keep going. And you can get caught up in their rationalizing and get an arguing with them. So we want to be careful of that. In terms of the ability to kind of keep attention, I find with the younger children, we want to look at, making it more interspersing activities, using child-friendly language. With teens, I'll often use things like technology, whiteboards. And then we want to also look at how dependent, sorry, my slides have a mind of their own, so I'm just doing my best here. We want to look at how dependent the youth is as well. So with children, as a therapist, you're going to have a much more directive approach, whereas with teens, it's going to be a more collaborative approach in terms of what ERP tasks we're doing, what are we addressing. The level that family is involved is important. Again, it's important for all ages for the family to be involved, but particularly with children, we want to incorporate parents as much as we can. And one of the reasons we want to do that is the parents themselves, they need to learn that the child can tolerate the distress and they don't need to rescue them. They also need to observe you as the therapist doing the treatment so that they can learn and generalize and take it to the home environment. And also they themselves may need to change some of their behaviors. With teens, depending on their age, you know, the parents will be involved, but you're going to get the teen's permission. We get caught up in that ethical dilemma of, you know, who is the patient? So often what I do with teens is talking to them at the beginning, understanding that there's a level of privacy that will happen to increase sort of that trust and compliance in the treatment. I often will get them to sign a consent form, even though I don't have to legally, but it just kind of helps them feel that you as a therapist will not be going running to their parents and telling whatever they're saying. It's important to be specific with the teen of what information you're going to share with parents, and then also to let parents know that if there is something you feel really needs to be addressed, that you will bring it up with the teen of how to approach the parents. And in both of these scenarios, parents themselves might need to change behaviors, so it is important that we involve them. And then finally, we want to look at how willing is the youth to engage in the treatment process. For both of these age groups, we need to have them make it worth their while. And I'm going to talk more about that in a moment. So as a therapist, you really need your patient to really buy into the treatment process. So by having them understand, you know, that what the goal here is that we want to increase your control and your influence over OCD so that you are going to be taking back control. You want to help them understand what are the risks and the benefits of doing the CBT treatment. You know, asking them questions like, what would it be like to live your life without OCD in control and telling you what to do? And then, of course, the goals you set with the teen or the youth is going to be based on what's important to them. We want them to understand that OCD is treatable. And the goal of treatment really is to teach your patients how to be their own therapist. The idea here is to learn to manage the symptoms. There's no cure for OCD, and they need to know that, but you certainly can learn to manage them. So in terms of willingness to engage with children, you know, we want to look at, like I said earlier, the parent is often brought in. They're going to have more control in what's going on. But you want to get the kids involved by externalizing OCD, helping them see it separate as from them. So often we give it kind of a silly nickname. We draw a picture and we kind of see it as this separate enemy that we as a group are now trying to ally and work together. You're going to want to talk in child-friendly terms. You're going to want to use language that they're going to understand when you're describing OCD, when you're describing what's going on in the brain and the treatment. Often when I'm doing ERP or CBT, I'm using games and I'm trying to make doing ERP and bossing back OCD as fun-ish as we possibly can. And for this age group, it's imperative that you are involving incentive programs. So they're going to earn points or stickers for bossing back and being brave. With teens, we kind of get this sense of, yeah, I don't really need help. You know, my parents kind of brought me in here and they may not want help or treatment and they may not even want to admit it. You're going to have to really use your motivational interviewing skills in this scenario. When you set goals, getting that teen involved, making sure it's equivalent to sort of what they're interested in. Often when they are unwilling to participate or they're being brought in by their parents, I try to ally with them, you know, and hey, you know, let's get, you know, are they going to stop bugging you? No, probably not. So let's just, they're going to keep bringing you. So like, let's just do an experiment. Let's just see if we can, you know, try and get them off your back. What do you think? I want them both to understand that I'm not going to force you to do your treatment. You know, the choice really is going to be yours. And again, finding out what the teen is interested in, sports, computers, etc., and using those analogies and metaphors to really try to relate to them. I still will use an incentive program with teens. It's going to be much more future-oriented rather than immediate, or they can reward themselves after doing the work. And then finally, if parents are accommodating the behavior, then sometimes we need to just talk to them about stopping that just to get the teen into treatment. So I want to talk a little bit about what we need to think about with family. I mean, OCD does not just affect the child, it affects the whole family. And so it's super important that we determine what level are the family members tangled up in these rituals. So we want to assess, are there any accommodating behaviors and symptoms that are happening with OCD. We know with research that accommodating behaviors will increase the severity of OCD and functional impairment. And so one of the tools that we can use is the family accommodation scale. And there's 3 versions of this. Working with children, I just use the first 2. The third one is really for an adult, but basically I'll either interview them myself or I'll have the parent do a self-rated version. And once we get that information, then we're going to determine, okay, well, how much accommodation is happening, and want to educate them about what the effects of that. And then finally, we want to look at, are there any other sort of family issues or conflicts that are happening at home or in general that are getting in the way of treatment? We know that if there's a lot of kind of negative cycle and talking and hostile or critical type comments happening, that it also can affect the treatment and stress in the home. All right, so I'm going to talk a little bit more about getting ready for treatment, and now I want to talk about psychoeducation. When it comes to CBT treatment for OCD, psychoeducation is actually a really important aspect of it. You really need to help explain what is going on in the brain, and you want to explain it in a way that's going to help them understand the rationale for the type of treatment you're going to be proposing. You want them to understand kind of that circular nature of OCD, seeing, as I said earlier, OCD as a bully or separate from the youth. You're going to want to describe what are the different treatment options and help them understand that. And then finally, if medication is something that's going to be used, using sort of medical analogies to help them understand that, okay, you might take medication and that's going to help, but you also have to do some things as well. You can change some of your behaviors. And so I'll often use the idea of, with diabetes, if you can be taking insulin to help with your sugar levels, but if you're eating lots of sugary foods, then you're countering the medication. And it's the same idea here. So your actions matter and what you're going to do. We think about OCD as separate, as an enemy. And if you're going to learn how to fight back and take back control from an enemy, you really need to know your enemy. So I want them to really understand a lot about OCD. First of all, to know that OCD is a neurobiological disorder. And so this helps them understand that this isn't your fault, right? It's not the child's fault. It's not the parent's fault. It's just the way that the brain has come together at this time and how the brain is wired at this time. I've talked about OCD as a bully. The Mighty sort of puts here, OCD is like having a bully stuck inside your head and nobody else can see it. I was using that analogy just yesterday with one of my siblings of someone who had OCD to try to help them understand what it was like for their sibling. But really, I want them to understand that, yeah, it's a bully and it scares you and it wants to be in control. And fighting back OCD is not easy. It's really quite hard. And so it's understandable that you are going to end up giving in, right? It's not your fault that you're doing what OCD says, because OCD is scaring you so much that you're believing that you're actually in danger. I want them to understand, how do obsessions and compulsions work together? So what we sort of see here is that, we all have thoughts that just pop into our head. We have intrusive thoughts. So I could be looking at a doorknob and saying, oh, I wonder if there might be some germs on that doorknob. And for someone who doesn't have OCD, that thought is just going to kind of pop on through, off it goes, just like any other thought in my head. But for somebody who has OCD, that thought is going to get stuck. And as soon as it gets stuck, then they start to put meaning to it. So I might look at that doorknob and have that first thought of, oh my gosh, what if there are germs on there? Oh, well, what if I touch it? And then I might give germs to my mom, and then she might get a disease, and then she might end up dying, and then it's all my fault. So I end up kind of putting lots of meaning to that thought. And of course, as you can tell, those types of thoughts are going to cause me to feel anxiety and distress. And I don't like that feeling, and I want to get rid of it. So I might discover that, you know, I could talk myself out of it. No, that doesn't make sense. There's no such, that doesn't make sense. Germs, I'm not going to end up killing my mom. Or maybe I learned that if I use my sleeve to open the door, or if I get someone else to open the door, or I wash my hands afterwards, by doing these behaviors, I get relief. And now the next time that I have that same scary thought or get in that same similar situation, my tendency is going to be want to either do that mental or that physical thing that I did that made me feel better. And that's how the compulsion, it's negatively reinforced. Okay. I want my patients and the youth and parents to understand that this really is the amygdala. So understanding what the amygdala's role is in the brain. The amygdala's role is to protect us. But what has happened with OCD is that it is protecting us by sending off an alarm message when it doesn't need to. And it's sending off a false alarm. And the reality, though, is that your body doesn't know the difference between a real danger and a maybe danger. And so when the amygdala is sending off this alarm of a maybe danger, your body acts as if the danger is real. And so it's important to help parents and the youth understand that what you feel, those feelings are 100% real. I want them to understand that OCD is a fear-based disorder. So what that means is that there is always a fear underlying the OCD. It also feeds, its two big ammunition is doubt and guilt. So it will throw that thought into your head, what if something bad happens to mom? And then guilt. If I don't do my rituals, and something happens to my mom, then it's all my fault. And it's these two that work together that then feeds and keeps that cycle going and makes OCD stronger. The other thing to know about OCD is it goes after what is most important and what people hold close to themselves and is dear to them. So for children, it will often go after parents. Teens, it might go after friends. Parents, it will go after your children. OCD also likes to take advantage of sort of where the youth is in their developmental stages. So we'll often see with puberty that it might, there's typical sexual curiosity happening. So OCD will take these types of normal thoughts that pop into people's heads and it will twist it. So it might have a thought, an image of, kissing my best friend. And then the OCD might say, oh, what does that mean? Does that mean that you like her? What does that say about your sexuality? Does that mean you're straight? Does that mean you're gay? Does that mean you're bisexual? And it will twist these kind of just normal types of thoughts as well. So that's how it takes control. So really with OCD, what we want to do is we want to teach the amygdala. We have to retrain that amygdala. We need to teach it to stop sending that false alarm. And we have to change the wiring in the brain. So the way to do that is to help your patient, parents as well, change their relationship to what they think about as uncertainty. What we know about OCD is that the only way to fight it back, the only way to take back control is to learn to live with not knowing for sure, to learn to live with the possibility and take the risk of that, the possibility of what you're afraid of may be true or may happen. A few years ago, I did an interview with Corey Hirsch, and it was either in the interview or just in our talking, but he talks about a skeleton key for OCD. And he talks about accepting uncertainty as the skeleton key for OCD, which basically means that when you can accept uncertainty, you can open every single door that OCD closes. Now, OCD is no longer an anxiety disorder. It is in its own category with obsessive compulsive related disorders, but anxiety is a big part of it. And so I have sort of 3 take-home messages that I would like my patients to sort of understand. And the first one is that it's normal. It's normal to feel anxious. It's okay to feel anxious. And in fact, all of us do. We all do during challenging times in our life. And in fact, we actually need some anxiety in order to perform well. You can see here, Woodstock has no anxiety, and now he's covered with snow. I will show them sort of this graph to sort of understand what that relationship between anxiety and performance is. So with a low amount of anxiety, we're not going to do well at things. We need some of those jitters. We need some of that anxiety to motivate us to do well. And then when we have too much of anxiety, then we see that we also don't perform well. The second point that I want my patients to understand is that, okay, I know it feels horrible to be anxious. It is not a fun feeling. It is icky. It is gross. It's unpleasant. I've had clients actually pass away in my office. I've had clients throw up, luckily not in my office, but because of anxiety. And I've also had clients tell me how they've had gone to the hospital because they thought maybe they were dying or having a heart attack, or had ambulances called to their home. And people sometimes think they're maybe going crazy. So I want them to understand that as uncomfortable as anxiety feels, it's actually not dangerous. You're not going to die from getting, feeling anxious or doing ERP or eliciting anxiety, and you're not going to go crazy. And then the third point around anxiety is that, well, basically, we cannot stay in that highly sympathetically aroused state for a long period of time. It is too hard on our body, both mentally, physically, emotionally. And so what happens is our body has to reset. So what we know about anxiety is that over time, anxiety goes up and then it comes down. And it does this 100% of the time. Now, the problem is, what happens when anxiety gets too high? Well, that's where people can't handle that feeling. And so they may do their ritual. They may get reassurance, ask from themselves, from other people, that what they're afraid of isn't, true. They might escape the situation. They might do some relaxation strategies. They might distract themselves, or they might try and talk themselves out of whatever it is that they're afraid of. And by doing these things, they are then going to feel better. They actually bring that anxiety down and they feel better. However, what happens is the next time they have that same scary thought or in that same situation, and they get that false alarm, whatever they did before, they're going to do it again. And so this is that loop we talked about earlier. And I kind of sort of say to people that, OCD wants you stuck on this half of the graph. Because as long as you're on this half of the graph, OCD is in control. And OCD doesn't want you to know the truth, which is that if you don't do anything to feel better, that anxiety is going to come down all by itself. And that's where we get you in control. So basically, I want them to understand that, yes, we can reduce the anxiety, but that's actually just going to make OCD stronger, because anxiety is not actually the problem. The problem is the fear and that false alarm that is coming from the amygdala. The problem is that the response that the person is doing to that false alarm, so the compulsion or the ritual. I want them to understand that I know that it's, you do actually make a choice. You have a choice. You choose to do the ritual or not do the ritual. Now, I understand that OCD scares you so much into believing that you have to do the compulsion, but truly the choice is yours. And then finally, I want to sort of ask them, what you've been doing to help get yourself rid of these obsessions, has it worked? And I'll often get, well, yeah, kind of temporarily, but then they come back. And so at that point, I'm like, well, let's try something absolutely and completely different. So what is the treatment for OCD? So I'm going to talk in general what we know. I'm not going to go into depth around any of these studies, but there have been multiple studies that have shown that CBT outperforms talk therapy, outperforms placebo, outperforms waitlist, outperforms relaxation therapy, and anxiety management. And we also see, if we're looking at the difference between medication and CBT, basically we see that both of them work. So CBT works, medication works, and a combination of the two work. With CBT, when we look a little closer at all of the different studies that have been done, we actually see that what makes it work, the lasting effects of it, is really the exposure coupled with response prevention. So there, when we look at ERP compared to CBT without ERP, compared to cognitive therapy, well, ERP outperformed all of those other modalities. And so really we're saying that ERP and CBT is the first line of intervention for OCD. And with children, we also see the same thing. It is the treatment of choice with respect to its efficacy, the safety, and response durability. There have been multiple reviews and meta-analysis. Grebe et al. Has done a more recent one, which really are suggesting that CBT is the first line of treatment for youth, and that we are seeing that not only can it be done in programs, but also that the durability of it is seen over several years. We see that not only can it be in different communities, we see it generalizing, but we see it generalizing across different countries as well. So really, we know that this is what we want to do with children. And another piece that I wanted to focus a little bit on is family-focused CBT. I talked about the importance of family. Well, the reason we want to bring family in so much is that there have been like multiple reviews that have found that when we incorporate the family, and family-based CBT really is where you, in a structured way, you're bringing the parents in, and they are educated, and they're also taught how to do the ERP as well, and then manage the symptoms. And so when that's done, we see that there's less symptom severity and better treatment outcome when we compare this to psychoeducation and relaxation, or even individual CBT, and that these gains have even been up to 7 years. So we're seeing strong evidence for both individual and family-based CBT. Now, there's sometimes that we are looking at just that maybe the child doesn't want a treatment. So Eli Lebowitz and his colleagues have created the SPACE program, which is supportive parenting for anxious childhood emotions. And this is really where the parents are receiving the treatment, and they're learning about how does their behavior affect the child's anxiety. And so just by doing parental change, they found that they can reduce the anxiety symptoms, they can reduce accommodating symptoms and parenting stress. And this was done primarily with anxiety disorders, not specific to OCD. But this was in a controlled way, but they found that there was no difference in terms of whether you see the child or you see just the parents. So this is a really good alternative when the child isn't willing to come into treatment. There still needs to be some studies that are controlled done looking at pediatric OCD. So what is CBT for OCD? Well, the cognitive part is to teach the youth to respond differently to the obsessions. The behavioral part is to change the actions that they're using to decrease their anxiety. And Dr. Fred Penzel says it is the behavioral part of CBT that gets you better. It is the cognitive part that keeps you better. So I'm going to talk a little bit right now about how do we respond differently to the obsessions. A big part of cognitive therapy is teaching the youth and the parents to recognize that the assumptions that they have are problematic unhelpful and feeding into the OCD. So some problematic assumptions are things like, because I have this thought, it means it's true, or it means it will happen. Because I have this thought, it means I must want to have this thought. I must avoid feeling anxious. I can't handle the anxiety. I can't handle uncertainty. The cognitive strategies do not include trying to prove that the fears are untrue. So we're trying to help them look at the distortions they're having, but we're not trying to challenge the reality of the fears. So we're not going to use logic. We're not going to rationalize about the probability of getting sick or of something happening to someone we care about. Instead, we're going to use this piece as the educational component for them to understand the irrationality that is driving the assumption. So we don't want to get caught up in the content of the obsession. So when I'm working with kids, I talk about kind of these tricks. You need to be 100% sure that these scary thoughts aren't true. You can't handle them. If you don't listen to me, then the feeling won't go away. And then I teach them the truth. Well, you know what? It's not possible to be 100% sure because we can't read the future. It's normal to have these feelings and you can handle it better than you think. And eventually will go away if you don't listen. But if you listen, then OCD is going to just bring back that scary thought. A lot of things we sort of see out there is, hey, let's just, replace that bad thought with a good thought. So why doesn't that work? Well, we see it's not enough to eliminate the negative. You must fill your head and your mind with positive things. Well, if we do that with OCD, it might help them feel better in the short term, but it's going to cause that rebound effect and the obsession is just going to come back bigger and stronger. Well, what about the idea of just, don't think about it, push away those thoughts, ignore them? Well, if we try to do that, again, we get that rebound effect. The more we push away the thought, the more it's going to come back. Can't you just stop thinking about it? Can't you just stop thinking about it? Well, how do you stop thinking about something that's actually in your head? If I say to you, don't think about a pink elephant, I'm suspecting, I can't see anybody, but I'm suspecting that most of you are thinking about pink elephants. What about challenging? What about getting that rational brain in there and challenging that thought? Well, we don't want to argue with the content and challenge the obsessions because then OCD is just going to use its big ammunition of doubt and guilt, and it's going to end up making it stronger. So what do we do? Well, the truth is, the only way that we are going to be able to help take back control from OCD is to accept the possibility that that obsession is true. Voltaire has this quote: "Uncertainty is an uncomfortable position, but certainty is an absurd one." So what are we going to do? How are we going to use these strategies? Well, first of all, like I just said, we want to agree with the possibility and the uncertainty of the fear. Yep, it's possible. It could happen. We want to trick the amygdala by agreeing with it. Teach the amygdala. Help it learn. I often talk about using kind of a, whatever, roll my eyes, teenage attitude. Because by responding to it with that attitude, you're taking away the emotional importance of the obsession. We want to acknowledge that and externalize OCD. So acknowledge that it's an OCD thought and externalize it. As I said, we don't want to talk back or argue with it. Thought really isn't that important for me to have to address it. And then by doing this, what happens is the patient will start to habituate and get used to the thoughts and allowing them to be there and accepting them and the feelings that come from them. And then we also can use cognitive strategies to create positive self-statements that we use to motivate and to tolerate ERP. So here's some sort of examples that I'll often have kids say to their bully. Just acknowledge it. Hey, hi OCD, hi beastie, hi tricky trickster. I guess you're hanging out with me today. Okay. Sure, OCD, whatever you say. Okay, yep, that's right. You're right. I'm going to hurt myself. Yeah. You don't have any superpowers. You don't know what's going to happen in the future. Yeah, maybe I will hurt myself. Maybe I won't. Yeah, maybe someone will break in our house. Maybe they won't. I don't have to do what you say. You are not the boss of me. Sure, you can hang out with me, can say whatever you want. I don't really care. I'm just going to keep on doing what I'm doing, and let's just let you be there. All right, that's a little bit around the cognitive part of treatment. Now what I want to talk about is putting together the toolbox and identifying the fear. So the behavioral part of CBT is exposure and response prevention. And exposure and response prevention is where you are exposing the child or youth to a triggering situation, place, object, thought, or feeling. And this can be done by either flooding them, which means like throwing them right into it, or doing it in a more gradual way. And then once they're in that situation, you want to encourage them from doing their ritual or really doing anything that's going to make them feel better in that scenario. So the way that ERP works is that relationship between anxiety and time, the fact that anxiety is going to come down if we don't do anything to feel better. And so basically, what's happening is as we're doing ERP, the patient or the youth is learning that if I don't do my compulsion, that anxiety comes down all by itself. They also learn that, I didn't really like that, but I can actually tolerate that anxiety better than I thought I could. And finally, they learn that whatever it is they're afraid of does not necessarily happen. It could happen, but we have to, which is why we sit with that uncertainty. Now, when you're doing ERP, you're retraining that amygdala. Now, the amygdala, for it to learn, it needs two types of habituation. It needs what we call within trial habituation, which means within each trial, the anxiety, you have to stay in contact with the trigger long enough for that anxiety to come down. It also needs between trial habituation, which means that between each trial, it gets easier and easier. So what that means is we need repetition. So it's kind of like riding a scary roller coaster. The more times you do it, the easier it becomes. And so repetition is a big part of ERP. So we're retraining the amygdala. We cannot talk the amygdala out of the fear because it's in the feeling part of the brain. It needs to feel that the situation is not dangerous. And so when they're in that triggering situation, if the youth acts as if the situation is not dangerous by staying in contact with the trigger, by not doing their ritual, by not doing anything to feel better, then eventually the amygdala learns that, okay, well, you're not doing what you're supposed to do if something's dangerous. So I guess it's not so bad. And so maybe I don't need to keep sending this message. And so the anxiety subsides and habituation occurs. And then once the amygdala learns that it's not dangerous, then it eventually will just stop sending that false alarm. All right, I want to talk a little bit about before we start ERP, we need a set of tools. It's the same idea that if you are learning how to ski, you're not going to go to the very top of the hill and go to those double black diamonds and then just come on down. Before you do that, you're going to have to learn different skills to be able to do that. Well, it's the same thing with ERP. We need some tools before we get started. So naming OCD, journal, anxiety scale, and a fear hierarchy. Why do we give OCD a name? Well, I've already talked about it a little bit, but it's really an opportunity to just have everyone see OCD as separate from the child and all of us to kind of come together as allies to fight back this common bully or this common enemy. It's important when the child gives OCD a name that it's a silly name and related to their OCD. So we don't want a scary name. So these are some examples. I had someone, so they called their OCD mean machine And the reason is because OCD, just like a machine, just keeps on making bad thoughts. This little one called their OCD Spicy Trickster. And the reason was because, you know, it's tricking them. It's a trickster, it likes to trick them. And then finally, this girl, she called hers Mean Man, because, and Mean Man was telling her that she was going to get sick. And so she wrote all over, you know, you're going to get sick, and little pictures of angry people. So once we kind of have giving OCD a name, and the second tool that we need is the journal. And this is really an opportunity where you, as the therapist, get to do sort of your functional assessment. So where is OCD bothering them? How is OCD interfering in their life? So often what I get people to do to try to have an understanding of that is to look at life in the day of, you know, start from the beginning of the day and go to the end of the day. How did OCD bother you? We want to look at how are parents involved in the OCD, and whether or not, and that sometimes I get them to actually journal their own involvement. And then also anything that the child avoids is going to be in that journal. We need an anxiety scale. So this is where we are going to rate how much anxiety is being triggered by OCD. So with young children, I use a fear thermometer. This one's from Anxiety Canada, and ask, how much is OCD bothering me? How hard is it for me to not listen to OCD and to resist my ritual? And then with teens and adults, I'll use sort of a fear or an anxiety scale. An important aspect is to identify the fear. We need to help them identify the fear. Using the journal, you can start to do that. And then asking some questions about those times. You know, what were you afraid of? Well, that my sister could get COVID. Well, if that's true, that your sister could get COVID, what's so bad about that? Well, then she will die. What are you afraid of? Well, that someone could come in our house. And what's that say about the future? Well, mom or I could get assaulted. So we need to identify that fear, because from that, we can kind of do our formulation here. This is adapted from John Piacentini. And basically, you know, you're having your formulation statement, which then talks about what are your triggers, what do you have to do to neutralize the anxiety, and then what's the fear and the feared consequence. With young children, they will have a hard time being able to explain or voice that. So often I'll kind of use thought bubbles where I'll have them, you know, with my wonderful drawing skills, I'll draw something and get them to kind of, you know, what's in that thought bubble, or have them draw it themselves. I'll also will tell stories of other kids who might have similar types of fears and see if they can relate to them, to try to get a sense of what their fear might be. Once you have this information, then you can develop your triggers and you rank them using the fear scale, and then you put them on a hierarchy. When I'm working with young children, I will do what's called a Bravery Ladder, and letting them know that, you know, when we start to challenge OCD, we're going to start at the lower rungs of the ladder. So those are the things they rate lower. And then as they get stronger and win against OCD, then we're going to start moving up the rungs of the ladder. If there's more than one fear, then we're going to need more than one ladder. So if there's a fear of making a mistake and a fear of a bad thought happening, then we're going to have two separate ladders. So what I thought really quickly I could do is just go through some examples. This is a 9-year-old who had a fear of getting sick, a fear of germs, throwing up. She did excessive hand washing to the point where she was raw, repetitive questioning, avoidance. And so we created for her a Bravery Ladder. And you can see on the bottom are some things that are like looking at sick emojis or the words related to sickness and working with those words. More in the middle were things like touching items that were contaminated or looking at pictures of people who were sick. And then up at the top were things like watching videos of someone throwing up. And we started with animated and then animals and then moved into people. And then finally at the very top was actually eating Skittles off of something that was considered a contaminated item. Anne was someone who was worrying about hurting people's feelings and worrying that she was a bad kid and that God could be punishing her. She would confess and ask for forgiveness a lot. A lot of repetitive behaviors at bedtime and very specific bedtime routine. So for her, the lower items were starting to make changes with the parent, what the parent was saying at bedtime, what she was saying at bedtime, and just reducing some of those. More in the middle were things like, telling a white lie or playing a game with the family and cheating. And then finally up at the top, we're saying some of those bad words and maybe looking at pictures of the devil or of hell. Julie's interesting because she was a 16-year-old who I had seen when she was much younger. She actually didn't really do ERP treatment. She said she was doing it, but she wasn't telling the truth. And so what was happening is she was reassuring herself and feeling better, but by this point, she was really getting these violent, intrusive thoughts. And so at this point, she was really motivated to come back and to do the work. She was really, truly afraid that she wanted to stab her parents or other people, and she was afraid she was going to act on it. She used a lot of mental rituals. She'd talk herself out of the fear. She would push away the thoughts. She'd distract herself. She would take pictures on her phone as a timestamp to prove where she was or that she wasn't there when this item thing happened. She had to tell. There was this need to tell mom about all these thoughts and get reassurance. So for her, we had the hierarchy. We start with some lower items like just using scissors when mom's around. We moved up to sort of cutting vegetables when mom's around, not texting or checking in with mom. And then up at the top were things like watching a movie around harm, not confessing. And we also had her holding a knife. Now, it was too much to go straight to that. So in this scenario, when there's too big of a step, we will create a mini hierarchy. So the mini hierarchy for knives was I started with just pictures of animated knives, then had her drawing knives. Then we had pictures of like less sharp knives to sharper knives. Then we had looking at a real knife, a plastic knife, holding a knife, a sharper knife, getting to the point where she was holding it and then kind of doing the stab position and motion with it, and getting her really used to knives. Mike was a 15-year-old, and he had come from a faith-based background and had moved to a new school where he was confronted with teenage bad behavior. So he was afraid that he would not tell the truth. He'd act immorally. He was avoiding images and situations around drinking and smoking. He would mentally in his head go make sure he hadn't told a lie, and he would be confessing and apologizing. So with him, again, we started with kind of alcohol and cigarettes and vapors and having him look at sort of pictures of it, and then looking at a real one, holding a real one. Cursing without apologizing was a little bit harder for him. And then I even had him kind of mimicking smoking with the vape as well. Okay, so those are some examples of creating a fear hierarchy. So overall, what I want you to understand is how important it is to just look at where the youth is developmentally. And as you're speaking to them, be direct, but also talk in a way that they will relate to it and understand and will buy into the treatment. We want to identify the fear and the feared consequence and go after it by accepting uncertainty and doubt and taking risks. You're going to create individual fear hierarchies related to a specific fear, and ensure that if the steps are too large, then you can use a mini hierarchy. And then finally, we want to teach the patients how to talk back to OCD as a bully and accept the obsessions as possibly true and not challenge the reality of the fears or push them away. All right, well, thank you very much. And I'll open it up for questions.
Thank you, Dr. Sapp. Just while they're posing their questions, I will just post the post-evaluation.
Okay.
And there will be another question afterwards because we do want to know from where you are attending today. So I'll give you 5 or 6 minutes or so, then I'll post the next one.
Should I start answering some questions? Is there what did you say? Wait.
No, absolutely. But I can't see any questions.
Oh, I see a couple.
Oh, okay, sorry. For some reason I can't see. Please do. Yeah. Oh, I can now. Yes.
Okay. So first one I sort of see is to share the games I use with children. Oh, wow. The games aren't anything specific. It's just me playing games. So basically when I'm doing ERP, I sort of think about, I have kind of like an arts and crafts section and kind of a games. And so I will, or I might play games such as, you know, keep away. So if there's something that they might see as contaminated, we might touch a Kleenex to that item and then have them play keep away with that Kleenex so that they have to touch that contaminated Kleenex. I'll talk a lot more about this in the second webinar because I'm going to give more examples of some of the ERP tasks in detail. And other things are things like follow the leader, and we might go around and touch things that are contaminated. I'll touch them first, and then they'll follow the leader. I'll do singing things, so we'll sing songs around, you know, around what they're afraid of. You know, let's all throw up, let's all throw up. Like we just kind of try and do it in a fun way to engage them. I'll use iPads now, especially where if I have a picture of someone who maybe is afraid of, I had getting cancer. I had a child who was afraid of getting cancer. And so we had a picture of like Terry Fox, because that was one of her really high ones. And she would just had to look at that picture, but then also could draw on it and could write things all over it. And so it's kind of much more engaging than just staring at a picture. Okay. Another question here. Can you share the accommodation scales you quickly shared? Yes, I can. So if you want to email me at the address I provided at the beginning, I can share that. Or if there's a way that I can do that, Julian, through.
Yeah, if you'd like to contact me, I'll get them from you, Dr. Sapp, and I'll pass them on.
Oh, I can't actually give you the actual tools, but I can give you the website of where you can find them. Yeah.
Okay.
Are there comorbid issues that would complicate or alter how ERP is administered, or maybe make it not a viable treatment? Yes. So first of all, there are definitely, so in my third webinar of, I think, was it last year, I actually talked a lot about sort of challenging cases. And one of the things I did talk about was comorbidity. So for example, I think I'll just use an example of eating disorders or depression. So if that comorbid disorder is so extreme that the child is not able to engage in the treatment process, then we're going to need to address that comorbidity first. And for depression, you know, that's where we have to get on medication, or I might have to do some work around the depressive symptoms before we get them ready to be able to do the ERP. I think that answers that. You didn't mention having patients envision their worst case scenario while they do their exposure activity. Is this not part of the treatment? Well, that is basically, I should read it a little louder so everyone can hear. You didn't mention having patients envision their worst case scenario while they do their exposure activity. Is this not part of the treatment? It can be part of the treatment, but so when they are envisioning their worst case scenario, or you're doing what we can call an imagined scenario, I do have patients use those. The truth is, though, and again, I will talk about this in the next webinar because it is one of the types of ERP treatments, is that you have to look at where they are in their on their hierarchy. So if it's something, so I find when I'm doing an imagined scenario that it's usually much harder, and so that's going to be something we're doing later on in treatment. What I really do when they're, say, looking at a picture is, instead of imagining the worst case scenario, we're looking at it and we're letting that fear be there, so that they're letting those thoughts, and if their thoughts are the worst case scenario that come into their head, then they have to let them be there. Can you comment on differences between phobia of vomiting versus OCD? Oh dear. Okay, yep, with vomiting fear. So with respect to a fear of vomiting and OCD with a vomiting fear, in terms of differential diagnosis, you're going to, what I've seen is that when it's emetophobia, which is the fear of vomiting, the compulsions are not, well, there aren't necessarily the same types of compulsions that we would see with OCD. So you would see avoidance, but you wouldn't necessarily, so I'm just going to close that, you wouldn't necessarily see rituals happening at night to prevent something, them getting sick. When we see OCD as a vomiting fear, then there are rituals that are generally involved, and in both you're going to see sort of that reassurance seeking, avoidance, but with the OCD, there might be other rituals that don't necessarily make sense as well. And then also, the way I look at it too is if there are other OCD symptoms, then that fear of vomiting kind of falls more under that OCD umbrella than it would under a phobia. Oh, can you discuss the difference between tics and obsessive compulsive behaviors? I know there's going to be some great webinars coming up on tics and Tourette's, so I'm not going to go into detail there. But one of the big ways to determine, well, first of all, there is, because we are this group, obviously there is a comorbidity for some people. But with respect to a tic, it is a involuntary behavior or action. Whereas with OCD, the behaviors or the actions that we see are more voluntary in the sense that the person knows what they're doing, they have control over
it. Dr. Sapp, I just posed a question there. When would you, as the clinician, suggest medication in addition to CBT?
So there's a couple ways that I would suggest medication. First of all, it kind of goes back to that comorbidity question someone asked earlier, which is that if there is, for example, depression that is getting in the way, their mood is so low that they aren't able to engage in the process, then medication might be needed to kind of lift that mood. The other time is depending on the level of anxiety and severity. When the anxiety is so high that they are unable to engage in the treatment, then that's when medication will be addressed. Now, one of the things that does happen, so basically we know that having the two together, medication and CBT, is more effective for those higher severity cases. For the ones that are more mild or moderate, then CBT alone might be suggested. And then finally, if they've tried it before and they didn't have medication and they didn't succeed, then we might want to try some medication as well. Often I'll have parents and kids who they don't want to have medication. And so we will just kind of go along. And then if I'm noticing that things are kind of stagnating or we're just not kind of getting over that hump, then that's where I might sort of say, we might want to consider thinking about medication to just take that edge off the anxiety so the child is better able to engage in that treatment.